Hi, good day, and welcome to the first in the Mountain Pacific Quality Health MDS Coding webinar series. This month and every other month throughout 2020, we will host a webinar event. Today's topic is COVID and coding. On alternating months, starting in August 14th to be exact, we will have half an hour Q&A with our presenter, Jennifer LeBay. Jennifer is an expert in understanding MDS and accurate coding, so these open office hours, as we're calling them, will be a great opportunity for you to ask your MDS questions to an expert. As I introduce our presenter, Jennifer, I want to let you know how excited we are to be able to have Jennifer for the whole year. She has been an amazing educator and partner for us here in Alaska, and now we get to share her with our other Mountain Pacific Quality Health states of Hawaii, Wyoming, and Montana. So with that, I will introduce Jennifer. I'm not going to spend any time going into her credentials. She has lots of initials behind her name, and I don't know half of them. Most are related to her ANAC certifications. But what I think is most important for this audience is to appreciate the fact that Jennifer has been in the long-term care industry since 1991, serving as a CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. She's a master teacher with ANAC and is active with that group on a national level. So with that, I will welcome you to today's webinar entitled COVID and MDS Coding. As a note, all attendees are muted during the presentation. Feel free to chat in questions as we will be monitoring the chat. You may also ask to be unmuted if you prefer at the end of the presentation. With that, I will turn over the presentation to Jennifer. Welcome.
Thank you so much for that wonderful introduction. I am so excited to be a part of this group and to hopefully bring some clarity to the MDS coding with all of the craziness that's currently going on. So I bring you greetings and salutations from the East Coast. I am in Rhode Island. And welcome. I want to thank Mountain Pacific Quality Health for holding this webinar series, and I want to thank all of you listening for being here. I know this is an extremely difficult time, and I applaud your dedication and service to our most vulnerable population. And although we are in a public health emergency and the government has eased a lot of restrictions as it relates to Medicare coverage in the SNF setting, it has not eased all regulations. It also has not changed any coding rules for MDS or quality measure calculations. So we will talk about those as we go. So we're just going to briefly touch upon some of the things that this COVID waiver has done to our technical Medicare coverage under PDPM. If you have any specific questions related to these waivers, I have an open door, not just for a half hour next month, but my emails runneth over, and I am very happy to answer questions. I answer questions all the time from folks in California, from folks in Alaska, all across the country, and I'm happy to do it. If I'm available, I'll answer you. If I'm not, I'll get back to you as soon as I can. I love that piece of my offerings, and it's just something I love to do because for some odd reason, I get it. I understand it. It clicks with me. I've been doing this for a very, very long time, so I'm happy to help. There are several technical requirements to traditional Medicare. We're not talking about any of the managed programs or any of those other types of ACO or waiver programs, but traditional federal Medicare. Some of these traditional requirements have been affected by the COVID waiver, some have not. First, the resident has to be enrolled in the Medicare program. That hasn't changed. There has to be originally a qualifying hospital stay. This is now where our COVID waiver is going to be affecting our technical requirements. This has not changed with PDPM. These rules have not changed. We're in an unprecedented time with these COVID waivers. So we'll talk a little bit more about that. But that's definitely one that is affected by the current situation. 30-day transfer rule also may be affected by this current situation. The resident must have benefit days available. This has not changed either with PDPM or with the COVID waivers, except in some certain circumstances that we will talk about. We need to make sure that whatever we're doing, we're verifying eligibility, that they have the ability to access their Medicare. There's days available. If there's not days available and we're applying the waiver, that we know how to adjust the claim to show that so you don't get denied. And the MD must certify care. That has not changed at all, either with PDPM or with the waivers. The MD or non-physician provider or NPP must certify the care upon admission or as soon thereafter as is practicable to your facility under Medicare Part A. There is no set time frame for that certification, like 24 hours or 72 hours. If the MD was available to visit the resident, write a note, sign orders, then that is when the cert should be signed. Now, certainly with the current climate and increased use of telehealth, there may now need to be a need for more creative ways to get this done, such as faxing, sending to the office, perhaps utilizing your electronic health records, electronic version of the certification. There is not a requirement for the cert that it has to be in person. So those regulations can be met by those means. The MD NPP must recertify the care by the 14th day of the stay and then every 30 days thereafter. They have to sign and date in their own hand. That is key. Most of the MACs will deny your claim if that certification is not valid. Facility can't predate things. They can put a little sticky note that says, here's when it needs to be done, but the doc has to sign it and date it themselves. For more information on all of these pre-waiver technical requirements, you can go to Chapter 8 of the Medicare Benefit Policy Manual. So it's important to note that there are two major shifts in the technical eligibility for Medicare related to the current health crisis that essentially affect three of the technical requirements, as I just discussed. I'd like to make note that these waivers that have been in place are typically used for smaller geographical locations that are affected by disaster, like the California wildfires that occurred last year, hurricanes, tornadoes, things like that. And it's usually a much smaller geographical area. This is different in that the entire nation was included as part of this public health emergency. All 50 states currently have a disaster declaration. This has never happened before, ever. We are in uncharted territory. This waiver was released in mid-March and was retroactive back to March 1st. And that's with this little snippet here on the screen. So this waiver of the requirement of a 3-day prior hospitalization for coverage of a SNF stay provides temporary emergency coverage for the SNF services without a qualifying hospital stay for those who are evacuated, transferred, or otherwise dislocated as a result of the effect of the disaster or emergency. So again, this is a national emergency. This isn't just a small geographical area that has been deemed part of this waiver. It's the entire country. So all of the clinical criteria for skilled coverage must still be met regardless of these waivers. And there's a lot of debate and controversy surrounding this waiver, with great concerns about bankrupting the Medicare trust. But these are unprecedented times. Some experts are far more conservative in their instructions and guidance, even after guidance has been put out by healthcare organizations on the state and national level. CMS did release a frequently asked question, most recently updated on Wednesday. Unfortunately, there's not a lot in there surrounding SNFs. It's looking at the entire nation and how that disaster emergency is affecting other areas, not just our SNF setting. So in light of the relaxation of the qualifying hospital stay requirements, this will also in turn affect the 30-day transfer requirement when newly accessing Medicare. So if a resident is at a skilled level of care, they can be admitted to a Medicare Part A coverage without the 3-day hospital stay or that 30-day transfer requirement. This waiver lifts that and allows for more flexibility for the beneficiary to access their Medicare benefit. There does not have to be proof that there is COVID in the hospital or that this is a COVID-related coverage. This is a general blanket waiver associated with this public health emergency. So this is from the frequently asked questions. It's dated 4/10, but this is when the question was first added to the frequently asked questions. Does this waiver for the 3-day qualifying hospital stay apply only to those beneficiaries who are actually diagnosed with COVID, or does the waiver apply to all SNF level beneficiaries? So as I said, that qualifying hospital stay waiver applies to everybody, regardless of whether they have a direct relationship to COVID, or even if regardless of what's going on in that hospital level. The hospitals may be trying to keep those stays shorter. Maybe the residents don't want to go into the hospital for fear of going into and contracting the COVID. So we want to make sure that we are looking at our folks who are potentially coming in for a skilled stay and that they meet the coverage requirements. That is the key piece. Do they have Medicare? Do they meet the clinical coverage requirements? If they had had that 3-day qualifying hospital stay, would they be eligible with the care that you are now currently providing in your facility? Days available and benefits exhaust. In the current public health emergency, the blanket waiver also states that a resident in the middle of their 60-day period of wellness does not have to achieve the entire 60 days to receive a new benefit period. Now, this isn't a Medicare coverage webinar, but if you have general Medicare knowledge, you know that we have to have a 60-day period of wellness for a beneficiary or resident to establish a new 100 days. So if they were in the middle of that, meaning they've already dropped skill after they've exhausted benefits, and now they're waiting for that 60-day period of wellness, and something happens in that they now become skilled and haven't had that 60-day period of wellness, they can access their Medicare for a new 100 days without that 60-day period. So for those folks who exhausted benefits and remained at a skilled level of care beyond day 100 through March 1st, they are not eligible for a 100-day period under this waiver, unless what they were continuing to be skilled for was COVID or COVID related. So there was a big question about, well, what about these people who are on tube fees? Does this mean we can give them a new 100 days? What does this mean? There was a lot of confusion when this first came out. So this snippet is from the general waivers for the 1135 waivers from March of 2019. The current waivers that are out and frequently asked questions are a supplement to this. So this is one of the main questions. SNF residents who are returning to an evacuated facility. Now remember, before this unprecedented time, this was considered to be for a much smaller geographic location that may have been affected by that current disaster. So if a resident previously exhausted the 100-day benefit period, was not discharged, but was evacuated for a few days, now back in the facility requiring skilled care, do they receive additional days? And essentially we'll look at that highlighted piece. Because the beneficiary at the time of the disaster was still receiving skilled care in the SNF after they exhausted 100 days of SNF benefit, he or she would not be in the process of establishing a new benefit period at that point, and they would not qualify. So if they've exhausted benefits because they had 5 days a week of rehab still, or a tube feed still, or a stage 4 wound that was being treated still on day 100, it wasn't COVID or something COVID related that prevented them from dropping skill. It was that tube feed that prevented them from dropping skill. It was that 5 days a week of rehab. It was whatever that skilling piece was. But if they did have COVID, and that's the reason why they weren't able to drop skill, they are eligible for a new 100 days without any break in skilled services, which is kind of bizarre, to be honest. It's nothing we've ever seen before. So this is just another frequently asked question speaking to that same question, verifying that no, this is not a free-for-all for everybody, for anyone who is skilled, that they can now get a new 100 days. But it wasn't really clear. So the big question was, what about if they're skilled related to that COVID emergency on day 100? Does this mean they get more than 100 days? So I sent an email to CMS for further clarification. And the response I received was that the person who exhausts benefit while receiving skilled care for COVID can indeed continue skilled care under Medicare Part A for up to another 100 days without a break in skill. The reason being is that COVID prevented the resident from establishing the new benefit period. So when this 100-day period starts, everything starts all over again as if they did have the 60-day period of wellness. So you'd have to start now. Day 101 is really day one of the new benefit period. We've got a new 5-day will be required. The variable per diem is going to be reset. The copay days will be reset. And there's certain things that need to be put on the claim in order to show that. It would be nice if there was some more scenarios put into the frequently asked questions. And I did say that to the CMS fellow I emailed, and he agreed. He said, well, basically we would love that too, except for all of these other pieces are kind of beating us to the punch, and they're having a hard time getting all of these pieces into the frequently asked question. But again, there's a lot of things up in the air based on the documentation that's out there. So whatever approach you take, whether it's more conservative, as some of my colleagues in the nation have been a little more conservative in their approach, you need to be consistent in how you do it in your facility and be able to argue your point if it was ever questioned. This might be something you would want to include in maybe some corporate compliance minutes, or if you have reached out yourself to any officials at CMS or your MAC or your state REI coordinator advising something different, save those emails, put it as part of your corporate compliance minutes. And we all know that emails are not policy, but in the absence of the clarity that we've been so desperately looking for the past several months, it may be all you have to argue any points. And it's going to be interesting to see months from now what the fallout is going to be of these disaster waiver claims. Days available, so that's another technical requirement. They have to have days available. So for a person, a beneficiary who comes off of traditional Medicare prior to day 100, that previous 60-day period of wellness issue does not apply to them. If they haven't had their 60-day period of wellness and they've come off of Medicare before they've exhausted benefits, that waiver does not apply. The piece that may apply would be the no qualifying hospital stay. So if a resident came off of Medicare prior to day 100 and they become skilled again within 30 days, and it's related to their previous skilled need or their previous hospitalization, they may resume the Medicare benefits where they left off. The waiver does not give them a new benefit period. This has always been the rule. If they came off on day 20, when they start within that 30 days, they'll be picked up on day 21 of their Medicare stay. If a resident comes off of Medicare and becomes skilled within 31 to 60 days, normally, in order for them to re-access that same benefit period, they would have to have a 3-day qualifying hospital stay. But now, because of the waiver, the 3-day qualifying hospital stay will not apply. They're not going to get a new 100 days, but they could access their benefit again if it was related to, potentially related to something they were skilled on before, or if it's meeting that skilled level of care criteria because they don't need that 3-day qualifying hospital stay with this waiver. They'll get up to their 100 days and then that's it. So whatever days they had left in their benefit period, unless they were skilled for COVID on day 100, and then they could continue on for another 100 days. So it can be very confusing, these different waivers and how it applies. If you don't have a real good understanding about technical eligibility for Medicare to begin with, this kind of throws a real fly in the ointment for understanding, because it kind of mixes things up. So I'm one who always likes to back things up with regulation and stuff straight from CMS. So here are some links for you. The blanket waivers, the last update I believe was 6/25, and the SNF information starts on page 14. And then we have the original frequently asked questions from March of 2019. And then the most recently updated frequently asked questions, which just came out this past Wednesday, which is a supplement to the March 2019 frequently asked questions. The stuff about SNF starts on page 99. There's not a lot about SNF, unfortunately, SNF related stuff. So all of the daily coverage requirements must still be met regardless of that technical eligibility waiver. Just because they didn't need the qualifying hospital stay doesn't mean they're automatically going to be covered under Medicare. They still have to meet the daily skilled need. It still needs to be reasonable and necessary. It still needs to be clinically appropriate. All of those pieces have not waived. So it's not a free-for-all for everybody, just a couple of those technical components. So just a note on COVID-19 and skilled coverage, just because somebody has a diagnosis of COVID-19 does not mean that they're automatically skilled. There's generally no blanket statement about coverage for any certain diagnosis. It's all about what's being done for the resident on a daily basis. So the ultimate factor in determining if the care rises to a level of skilled care covered by Medicare, as per Chapter 8 of the Medicare Benefit Policy Manual, the documentation needs to support what care and services are being provided to that resident on a daily basis. That documentation must support the care and services that rise to that level of requiring a licensed nurse or qualified therapist to provide or oversee that care on a daily basis. So it is probable, however, that a positive or presumptive positive COVID-19 resident will require, at a minimum, indirect skilled nursing care for observation and assessment. I would think that if you have somebody in your building who has a positive test or a known exposure and is now symptomatic, they're going to be on isolation. You're going to need to be doing some observation for symptoms, respiratory assessment, looking for any of those other symptoms that keep popping up with new symptoms every day. Do they have a cough? Do they have a fever? What do their lungs sound like? Do they have any clotting issues? Are there any blood disorders? What else is going on? What comorbidities do they have? So generally, in my clinical opinion, we should be doing that level of observation and assessment. Now, if we're not, then they're not going to rise to that level of skill. But if you are providing that daily service, just because they don't become symptomatic or just because they don't get worse, doesn't mean that you weren't providing skilled services. That is an indirect skilled service, and that is allowed per Chapter 8 of the Medicare Benefit Policy Manual. Some potential missteps, getting off a little bit of the Medicare piece of it and now diving into other aspects of how COVID might affect our day-to-day. Some potential missteps that I have seen with therapy is they don't treat the resident who clinically needs therapy just because they're COVID positive. And there could be many factors associated with that. Lack of PPE, lack of staff, maybe the staff is out, maybe you don't have the therapists, but just that, well, we're not going to treat them because they're COVID positive. If they clinically need it, if they've been in your building receiving the services, they had a fractured hip, they had a hip replacement, whatever it is that they clinically need these services for, a COVID-19 positive does not mean all therapy stops. So we are supposed to provide all of the care and services that are clinically required to the residents under our care. And not taking advantage of the telehealth options to provide services when clinically appropriate. There is some information about telehealth on that frequently asked questions starting on page 100. And they are allowing telehealth for PT, OT, and speech. Now, we'd have to be mindful of, is it really clinically appropriate to do telehealth, maybe for PT and OT to do an eval? Are we going to be able to do that? Because there really needs to be some hands-on component associated with that evaluation, but there are some things that can be done via telehealth. Now, I'm no therapist. I don't pretend to be one, but there are certainly some areas. I'm thinking maybe speech therapy. I'm talking with some of my therapy friends, like, when would this really apply? And those are some situations, but you'd want to look and see what is clinically appropriate, how would this work, and utilizing it. Is this something that maybe we can utilize in our facility so the resident doesn't miss out on needed care? Another area that our dear friend coronavirus has created for us is our ICD-10 coding. Now again, this is not an ICD-10 coding course, but in an unprecedented move, CMS and the CDC added updated codes outside of their usual October 1 update. This is unheard of. It's October 1 and that's it. They added a new code, some new codes for us related to this public health emergency, effective April 1. In addition, they updated the PDPM mapping tool effective April 1. So it's very important to make sure you understand, am I using the correct diagnosis? And am I applying this correctly in my facility? So anybody who was a positive or presumptive or confirmed COVID-19 case, the ICD-10 code was B34.2. But as of April 1st, we now have a specific code in place. They've added a new chapter, codes for special purposes under the coding guidance, and a presumptive or confirmed ICD-10 for COVID-19 will be U07.1. This is going to map to the pulmonary, which is the medical management category for PDPM. There are additional codes used for exposure or screening, in addition to the COVID-19 related pneumonias. Those are going to be returned to provider, the additional codes for exposure or screening. So it's very important to make sure that you have the appropriate codes, and I do have the link here for those updates for you to add to your ICD-10 coding manual. Also, we want to consider, what do we need to do for our Medicare folks if they do become COVID positive during their skilled stay? We've already established a payment with our 5-day assessment. Can we utilize the interim payment assessment? Now, again, not a PDPM course, but we should know that that interim payment assessment is an optional assessment that the facility can employ when it's deemed appropriate by the provider. So there's no instructions from the government of when to do or not to do the interim payment assessment. We may want to look to see what was our score before, and are we now providing additional care to that resident for nursing and for our non-therapy ancillaries? Is that something that maybe we want to capture an increased payment for the care and services that we're now providing? So if you do have a Medicare covered COVID-19 person, what is new for them? Do they have isolation? We're going to talk about the coding for isolation in a little bit. Do they have fever and pneumonia? That'll put them into the special care high. Just pneumonia, clinically complex. Do they have parenteral IV feedings that meet the CC and caloric requirements? That may affect your special care high or NTA points. Do they now have oxygen, IV meds, suctioning, malnutrition? So it's possible that the skilling for COVID may increase these nursing or NTA scores from that previously established assessment. Case management is vital for all Medicare residents, but especially if they become COVID positive. If your nursing score and NTA points are lower on your previous assessment than what it would be if you did a new assessment now, you most likely would benefit from doing an IPA. Even if your PT and OT and speech components drop in payment, you want to use your PDPM rate calculator, whatever you may have in your facility, to determine that. But in most cases, if your nursing and NTA points bump up, your overall payment is going to be higher. So now let's dive into the actual coding of COVID and MDS coding. To be honest, there really isn't much changed because the public health emergency has not changed the coding instructions from the REI manual. There are no special instructions that have been added. Interviews still need to be conducted as instructed. The rules of coding isolation has not changed. The only thing that has been relaxed with this waiver related to MDS is the timeliness of completion of the assessments and transmission. And that little snippet there is exactly all it says. So it doesn't say anything else other than they're waiving those timeliness requirements about assessments and transmission. So if you're late with assessments, don't worry about it because this should cover you, but it doesn't say anything else. If setting your ARD, they haven't talked about that. You still have to set your ARDs. You still have to do your interviews timely. But if you're late because you don't have the staff to do it, or you're pulled to the floor to do patient care and you can't get those MDSs done, set your ARDs, make sure that that stuff is done, but it may take you a while to get them completed, and they recognize that. So that's what is part of the waiver. Some potential areas of expected decline that we may see due to COVID being in our building and how this might affect our quality measures. You may see a decline in cognition in your residents because they're isolated and they have decreased social interactions and activities. Maybe a decline in mood because they're isolated, because they have decreased social interactions, fear about the virus, sad mood related to no visitors, they're bored, they're stuck in their rooms, they don't have, I know in some states we're starting to see a relaxation of now we're allowing some congregate activities, not all states are at the same area, but these people have been stuck in their rooms for months with no visitors. This is definitely going to affect them, mood and potentially cognition, decline in locomotion on unit because they're not out of their room, decline in late loss ADLs because of their mood, they're depressed, they're bored, what's the point? Nobody's coming to see me, nobody cares, I'm not going to take care of myself. It's a big snowball, to be honest, these potential issues with all of the things that are going on with this public health emergency. You may see increased behaviors related to mood. Isolation may result in increased use of psychotropic medications because of increased anxiety, maybe increased behaviors that are presenting in a way that they didn't present before because we had them out in activities and socializing and visiting, and we were able to interact more with these folks. Decreased improvement in physical function because of potential inaccurate GG assessment due to decreased staff interaction, decreased knowledge of GG instructions. Maybe we have limited number of staff who's going in to care for that resident and they don't understand all of the GG instructions. They're at increased risk for falls with major injury due to cognitive decline, mood decline, social isolation, increased behaviors. Now they have some increased weakness. They're not being monitored as closely because they're in their rooms. Increased risk for pressure ulcer due to decreased mobility, decreased cognition, decreased mood, increased time in bed, potential decrease in nutrition because of that decreased mood, and weight loss due to decline in mood leading to decline in appetite and intake. There are so many things that this public health emergency has affected with our residents, and it's going to unfortunately reflect in our MDS coding, and there's nothing we can do other than code what we see. If this is what happened, this is what happened. We need to make sure that we're care planning for it, that we're coding appropriately, and making sure that we're trying to mitigate some of these issues that we know we're seeing. So as far as these scripted interviews, so our brief interview for mental status, for cognition, PHQ-9 for depression, pain, and our daily routine and activities preferences. In the cases of quarantine or isolation, the interview still must be conducted. It is even more important now to hear the resident's voice because they're stuck in their rooms and they don't have their visitors and they don't have their advocates as much as maybe they did before. So we definitely want to hear the resident's voice. We can't just say, oh, they're on isolation, I can't do their interview. To decrease the use of PPE and decrease the number of staff interacting, the staff who must provide the care could be cross-trained to administer these interviews. So that could also be an area of concern because now these staff members who are potentially doing these interviews have never done them before. Oh, I just noticed a typo on my screen, I apologize. It's BIMS, not BIMA. So we want to make sure that they have a good understanding that the folks that are going in there and actually doing the interviews are able to do them appropriately, have them watch the video on interviewing vulnerable elders that CMS has out, or read the Appendix D of the REI manual with the interview techniques. Interviews could also be done remotely using platforms such as video conferencing, Zoom, for example, Skype, FaceTime, something, even though the resident is still in the same building, it might be easier if they have the means to do it that way. But we are still supposed to do these these interviews. So some common missteps with scripted interviews, even in light of, the COVID emergency or even before that, if the interview is not done timely, but we completed the staff assessment. So this does not follow the REI instructions. If the resident is interviewable and for whatever reason we did not go in a timely fashion and provide that interview, we're supposed to say at that gateway question that yes, they're interviewable. And then we have to dash the interview because we didn't do it. And then we're also supposed to dash the staff assessment, because the only time we're supposed to be doing the staff assessment is if we first said they weren't interviewable, or they could not understand and we didn't have an interpreter, or if they had an incomplete interview. Now, a missed interview, it does not meet either of those criteria. So the staff assessment should also not be done. If we do the staff assessment, it may inaccurately reflect a higher payment than what was due under PDPM. So we get a lot more money for the speech component if they are having some cognitive impairment. If the interview is not done and the staff assessment is not completed, they're going to default to cognitively intact, which is not as much money under PDPM. So it's very important to understand the coding rules in the REI manual. And as I said, staff not adequately trained on those proper interview techniques, especially with that cross-training in place for COVID. Make sure that the folks that are doing your interviews have a little bit of knowledge so we can get accurate assessment of those interviews. The PHQ-9 especially needs these special interview techniques, the unfolding, the disentangling, to make sure that we're accurately capturing those signs of depression, because as a person is more depressed, it's going to require more staff time to care for them. More resources are used. So the big question that has been circulating for months now is isolation, isolation, isolation. Can we capture it if they are cohorted and they both have COVID? No, you cannot. They have not changed the REI manual. The 4 very specific criteria is still there. I know it's hard to read on the slide, but this can be found on page -5 of the REI manual, which gives us our instructions for coding on isolation. All 4 conditions must be met. You need to make sure that you're familiar with the REI guidelines. So the resident first has to have an active infection, and it says underneath that instruction, either symptomatic or they have a positive test and are in the contagious stage. So if you have a COVID positive person or a known exposure and they're symptomatic, or they're symptomatic with those symptoms of COVID, that may meet the criteria for that first criteria. Okay, well, they're contagious. They are the ones that are having the infection and they are contagious. Standard quarantine post-hospitalization without known exposure to COVID does not meet this instruction. If we're doing it for everybody and there's no known exposure, we can't just presume that everybody was exposed. Unless we know there's an exposure or they're symptomatic or they have a positive test, they don't meet that first criteria of the 4. The resident has active infection with highly transmissible or epidemiologically significant pathogen that they have acquired by physical contact, airborne, or droplet transmission. So if you have cohorted 2 COVID exposed or COVID positive residents, they may have that active infection. They may be in their room and unable to leave. They may have precautions that are above and beyond standard precautions. But if they're not in a room by themselves, they can't capture. You can't capture isolation for these folks. It's not fair. We're still doing isolation. We are still providing that high level of care with those folks. They haven't made any changes. I don't know, what else to say other than we can't capture it. If there's a room change and there are, a period in that 14 days, because this is a 14-day look back on the assessment. If there is a day in that 14 days where maybe their roommate went out to the hospital, maybe there was a room change, something happened and that person is now by themselves, you can then capture isolation. If they're covered under Medicare, that might be a point where you want to add an IPA to capture that isolation, because that's going to show the care and services that were actually provided in that time frame. There is no percentage of days out of the 14 that they have to be under isolation. If they meet the criteria once in that 14 days, they meet the criteria. Another item that may show up negatively on your QMs is the ability to move independently has worsened. So this is assessing locomotion on unit, how a resident moves between locations in his or her room and adjacent corridor on the same floor. That is the definition. So you can't assume that because the resident stayed in their room that locomotion on unit did not occur. Locomotion in room is one component of this ADL, and locomotion in corridor is another. Now, although it says and, both don't actually have to apply because each one of these is a component. So locomotion in room, let's say, for example, which is a component of the ADL, is extensive assist. So they're extensive assist in their room, but they never leave their room. So their locomotion in the adjacent corridor is activity did not occur. In order to code activity did not occur on the MDS, it must have happened for all components of the ADL for the entire assessment reference period in order for it to be coded as activity did not occur. This is an exception to the rule of threes. It has to be all or nothing. So every single time that every part of this activity did not occur. So we can't code it as activity did not occur. The locomotion in room alone can be used to code this as extensive assist, even though the walking did not occur in the corridor because all components must be considered. And the walking in room component of the locomotion on unit was not activity did not occur. So components, if you have questions about this, you can find this on G-3 of the REI manual, but you really have to understand with all of section G ADLs is know what each episode of that ADL is and what each component is and all of the definitions associated. Section G is very, very tricky. I was very excited that section G was going away with October changes, but with all of the public health emergency, they have nixed all of the October 1 changes that were originally going to be happening for the REI, and section G is going to stay with us for a little bit longer. Mitigating decline in late loss ADLs. We want to ensure that the highest dependence is captured on the initial MDS. This is key whether we're in COVID or not. If there is a true decline, you want to make sure it's care planned. There is a wide range of abilities or disabilities within an extensive assist due to the definitions. So we want to make sure that we understand all of the components of the ADL, toilet use especially, that's broken down into different components. Eating, all of them are broken down into components. We want to make sure that we're capturing it appropriately on that initial assessment, so then we're not capturing a decline on the next assessment. A decline in 2 or more areas may indicate a need for a significant change in status, don't forget. So just to briefly touch on these late loss ADLs and the wide range of definition in extensive assist. So I teach it backwards. The first thing I want to ask myself is, did we provide total care for this resident for every single component of this ADL for the entire time period? If the resident was mostly dependent but helped you at least once, you code them as extensive assist. On the flip side of that, if the resident did almost everything and we provided total care for a small piece of it, or provided hands under assistance for a piece of that at least 3 times, that's also an extensive assist. So it's a wide range of abilities between these 2 definitions. It's very easy to code somebody as an extensive assist. This could be from feeding a resident 1 bite of food to feeding the resident all but 1 bite of food. All of that is an extensive assist. So understanding the ADL definitions and coding the definitions, that's key. You think you know? Well, you maybe need to ask somebody and double check and make sure, am I understanding this correctly? I found many errors in ADL coding, even by MDS coordinators who thought they knew that coding instruction, or just trusting what the CNA documentation said without going and talking to the staff and asking, okay, well, how many times on 3 to 11 shift, were they an extensive assist with their toilet use? And tell me exactly what you did for them. Oh, you had to wipe them each time. So you provided total care for a component of toilet use. If that happened 3 times, that's an extensive assist. So I find that even without the COVID emergency, I find that the decline in ADLs is triggering a lot because maybe we didn't capture their full dependence on that initial assessment. Mitigating psychotropic use, monitoring behaviors, discussing non-medicinal treatments with practitioners. Hopefully the use of any antipsychotics, anxiolytics, or hypnotics will be rare and temporary, and hopefully we can get folks back to their normal routines soon. Decrease and improvement in function, section GG, ensuring the staff who is assessing GG is well trained in the definitions, especially when using decreased number of staff, interacting with a resident, and making sure documentation supports GG coding. This has been a big misstep, again, regardless of COVID. So anybody who's involved with GG really needs to be properly trained. So CMS has put out some great training resources on this subject, self-guided and online. They have a YouTube channel with lots of great resources and videos. I particularly like the PAC training, which is the second bullet on your screen. They've added updates as recently as March 16th on the SNF-QRP training CMS page. Lots of videos that show you this is substantial, this is partial, and really gives a nice overview of GG. Fall with major injury, decreased staff interaction and supervision certainly may lead to falls. Hopefully they don't end up with a major injury, but it's possible. So what can we do in your facility to mitigate that risk? Maybe having some room changes, frequent checks, some creative roommate situations. You have a more alert person who could maybe be the, we don't have alarms that much anymore, but maybe that roommate can be, not that we want that roommate assisting the resident, but alerting the staff. Hey, they're getting antsy in here. Maybe some increased in-room activities and distractions. It's difficult having folks in their room 24/7. It's not healthy in all forms. Pressure ulcers, decreased mobility, they're lying in bed all the time because there's nothing else to do. So encouraging that movement in the room. Let's have, okay, get up and stand up. It's been 15 minutes, time for a stand-up break, or shift your weight, or some sort of something that we can assist these residents. We have to be creative, and I know it's difficult if we don't have the staff to do it. Maybe we continue to utilize those skin checks, maybe increase the frequency of those skin checks, have a dietitian review the intake and nutritional needs, maybe increase use of those barrier creams, pressure reducing devices, maybe adding a device that they never needed before, because it's just more comfortable to lay in bed and watch TV because there's nothing else to do. And now they're in their bed more. Weight loss, as I said, social isolation, decline in mood may contribute to that unplanned weight loss. So we want to have our consult with psych, dietitian, recreation. What can we do to help that nutritional status stay stable? So how do we manage this potential quality measure decline? Sometimes you can avoid decline. The key to the care that we provide is preventing avoidable decline and coding the MDS accurately per the REI manual guidance. Documentation is the key to telling the resident's story. We should be able to read that record, know everything of who, what, where, when, and why, and how they came to be, how this happened, what did we do, what didn't we do. The care plans need to be kept current and reflect all of the interventions to manage these concerns. And potentially, if your software identifies a QM trigger at the time of MDS completion, you could complete an analysis note similar to if a CAW triggered. I know in the past, way back a bajillion years ago when I was an MDS coordinator, I had a software that did that. And they were QIQMs at the time, that's how old I am, that I did those as if they were RAP triggers at the time. I did an assessment that same way. So I always had my documentation to support, why did this QM trigger and what are we doing about it? Here's what's in the care plan. We're already taking care of it. We're on top of it. So what about the 5-star in our quality measures? So SNF-QRP So that is looking at our Medicare residents. CMS is revising the compliance date for the SNF QRP to October 1st of the year that is at least 2 full fiscal years after the end of the public health emergency. So this interim final rule came out May 8th of 2020, and the link to that is on your screen. And this was a nice surprise, but there is still required compliance for calendar year 2019. So this does not change our fiscal year 2021 payment reduction, which starts this October. Just this week, letters were distributed if a facility was out of compliance. So your facility, if you received notification from your MAC or a notice in your CASPER folder, then you are out of compliance. If you didn't receive any of this, then you are in compliance and you don't need to worry about it. If you're not in compliance and you do want to argue a point, you have until August 18th at 11:59 p.m. to request a reconsideration from CMS. So looking at our 5-star, our health inspection stars, the survey stars have been frozen since any surveys prior to March 4th. The length of time has not been discussed. We don't know how long they're going to be frozen. The big focus is now infection control surveys, which do not affect your 5-star rating. They're also looking at the immediate jeopardy pieces. So this was from a memo that came out in April and was revised 7/9, that domain will be held constant temporarily. So what does this mean? If you had a great health inspection star rating prior to March 4th, you're going to retain that until they decide to start calculating again. Not so great if your health inspection rating was not that great. So a reminder, the health inspection rating is the starting point for the calculation of your overall 5-star rating. Staffing stars and quality measure stars may add or subtract from that starting point of your health inspection stars. So this was a memo that came out speaking to the staffing measures and the quality measures. So they are ending the waiver to the payroll-based journal system. This is not ending the waiver on coverage, just the payroll-based journal where we were on hold for reporting the Q1 staffing data. We will still need to report Q2 staffing data by August 14th of 2020. So don't miss that deadline for that Q2 staffing data. Staffing star rating will be held at a constant based on Q4 2019 data on the July 29th update. So they're not using Q1 data. That was January, February, March. Q2 staffing data, April, May, June, is still going to be used. So if you had a loss of staff related to COVID in April, May, and June for whatever reason, they had COVID, they were exposed and were on quarantine, or they just bailed, this data may negatively impact you on your October 5-star rating. Staffing rating of 1 may bring your overall rating down a star, and a staffing rating of 4 or 5 may increase your overall rating by 1 star. Q1 2020 data will not be used. So how do we mitigate this for our Q2 staffing? We need to make sure that we submit timely. So we need to get that Q2 data in by August 14th deadline. There's nothing you can do to change your staffing. It is what it is. It's already passed. But you can make sure that at least hopefully your census is accurate. If you've gotten behind in doing your assessments, remember the staffing is calculated based on the census, which is coming from MDS. If we haven't been sending our death in facility or discharge tracking assessments because we just haven't had time to do it, it may look like in a 100-bed facility that you now have 150 beds and your staffing rating is going to be staffing for 150 beds versus the 100 or less that you now have because you have been closed to admissions and now have no staff. So if you're going to do anything, get those discharge assessments and death and facility trackings done and submitted now, so your census at least is what it should be. COVID and 5-star quality measure rating. So per that June 25th memo, the rating will be held constant with the last quarter being 2019 Q4 ending December 31st. MDS-based measures normally calculated from a cumulative 4 quarters with the oldest quarter dropping off with each update. So there is a normal lag in reporting. July would have calculated Q1 of 2020 back to Q2 of 2019, with Q1 of 2019 dropping off. But now with the hold ending at Q4 constant, you're going to be looking at all of the quarters of 2019 for your data, which is certainly not current. So claims-based data will still calculate through July 2020. So the QMs may still change at the July 29th report based on the claims-based quality measures. So if your QM was not that great in Q1 of 2019, this does not help you. If you've been working on your quality measures in Q1 in the hopes of improving your rating, that's not going to help you now either, because Q1 of 2020 is not being used for that calculation. If you did have some falls with major injury or something this year, that won't be seen because it's only looking up until December 31st of 2019, so it won't be looked at yet. Claims-based, like I said, they're looking at a rolling 12 months that updates every 6 months, updated in April and October with a 9-month lag. So April updated the calculation of claims-based measures from July 2018 to June 2019. In October, it will update to January 2019 to December 2019. So the claims QMs will still update and potentially change your QM rating and overall rating. QM of 5 stars may improve your overall rating by 1 star, and a QM of 1 star may decrease your rating by 1 star. So what does COVID mean to your next 5-star rating? So the rating that's coming out end of July, July 29th, your health inspection rating is on hold for any surveys prior to March 4th. Q1 staffing data will not be used to calculate your rating for July, but Q2 will be used for the October update. Any clinical MDS declines that would be captured during the public health emergency will not be affecting your quality measures affecting the 5-star rating at this time. QM stars may change due to the lag in reporting of your claims-based measures, but not your MDS-based measures. So because the surveys are immediate jeopardy and infection control based only, surveyors are not going to be using the Casper QMs for survey. It's unclear when the normal surveys will resume or the timeframes that surveyors will be using the QMs for survey prep once they do resume. Other entities may utilize Casper QM, such as insurance or ACOs, but generally they're looking at the publicly reported QM star ratings, not the Casper quality measures. But continue to look at those Casper quality measures for your internal review. Just because people aren't looking doesn't mean we shouldn't be looking. We still need to be using that wonderful data to help continue to improve the quality in our facilities. And just a quick note just on how COVID-19 waiver affects your billing, just as a last piece. Any resident on Medicare A that has part of that COVID-19 waiver should be using a condition code DR on the claim. This will allow you to not have a 3-day qualifying hospital stay on the claim. It will also allow coverage for somebody who has not completed their 60-day break and skill. There are some additional instructions if you want to share with your billers. For the MLN matters, SE 20011, which was revised on July 8th. So for some additional information for that. Whew. So that's a lot of information. There's a lot of things that COVID has affected. I do see there was a lot of movement in the chat. So I do have a little bit of time for some questions, maybe a couple of questions.
Jennifer, this is Lisa. I also see a question in our Q&A box that was put on early. And it's, if you're putting a new admission in quarantine, a negative COVID test, non-symptomatic, in a private room, as that is recommended by CMS, could that be considered isolation? For quarantine, masks are recommended, but with isolation, full PPE is recommended.
If they don't have an active positive or they're not symptomatic, they don't meet that first criteria. So unfortunately, no, they would not meet that.
Okay, and I see one other question. I don't believe this got answered, but I'm going to double check. It says that the resident exhausted her benefits on July 10th, admitted back to the acute on July 11th. The admitting diagnosis was not related to COVID-19. When she returns to the facility and she qualifies for a SNF LOC, will Medicare A cover?
If she exhausted benefits July 10th and went to the hospital July 11th, there was never a break in skill and it wasn't COVID related. So unfortunately, no, they would not be eligible for a new 100 days at that point.
Great.
They
So
would be considered, if they're still at a skilled level of care, they would be considered, and depends on how your electronic health record does this, but they'd be considered a skilled no pay. So the benefits exhaust claims would still need to be sent by your biller. You'd still have to skill them and do everything that you need, but because it wasn't COVID related, they don't get another 100 days. That waiver doesn't apply. There would have had to have been at least one day in between that they dropped skill. And in this case, they did not.
great, thank you. I think maybe we have time to finish up just a couple more. I
Okay.
see one question in chat. Can a patient that meets criteria admit to a skilled facility with no hospital stay? If they were injured remotely and did not travel to a hospital for care, but now the PCP and the remote clinic feels like they need a skilled stay for therapies, can we admit them without any type of hospital stay?
Absolutely. Absolutely. And I know that there is, like I said, there's other experts in the country that are far more conservative about this and saying it has to be COVID related or that the hospital had to have turned them away because they're COVID full, but that is not the case. If they meet a skilled level of care criteria in your building, they do not need that qualifying hospital stay. And that's when you would use that DR on the claim. But as long as they clinically meet skilled coverage requirements, then absolutely.
Great. Those are the only questions I'm seeing. Let me pop back into the Q&A and see if I've missed any. Several folks are asking about the slides, and we will be sharing them along with a link to the recording. So
Great. And I do have my contact information on the screen, so please, if any questions pop up, I'm happy to answer them in between, and then we'll also be back for our open office hours.
I think it's really exciting to be able to say, you know, as you're thinking through some of the things that Jennifer's talked about and applying the tips that she's given you, it's great to have an opportunity to circle back and ask some questions. So next month we will be doing a half an hour. No agenda, just open office hours. Feel free to bring all of your questions about MDS, about coding. This is a really just great opportunity to ask our expert and friend. So thank you for our presentation today.
Oh, thank you very much. And any questions, bring them on. ICD-10, Medicare, all that stuff. Happy to do it.
Great. Well, thank you. I don't see any other questions. And we are at the 12 o'clock hour, so we'll go ahead and wrap it up for today. We will be sending out the slides and a Zoom recording. Feel free to send questions to myself, Jennifer, any of the Mountain Pacific contacts in our various states. We're all here, happy to help you. And thank you for joining us today.